seizures, which is really most of the time a pediatric disorder that pediatrician can deal with them without most of the time needing pediatric neurology for help, but sometimes we are available. And I will go a little bit through the incidents and clinical presentation and some red flags. And meanwhile, I just cannot move the screen. So what happened now that it's, oh,
there you go.
Okay. So what I would like us to understand today is the difference between simple and complex febrile seizures, identify the risk factors for recurrent febrile seizures and the risk factors for developing epilepsy, identify some red flags, and know the workup and treatment for febrile seizures. So febrile seizures are actually the most common seizures of childhood, and these are convulsions that occur in a child in the setting of a temperature greater than 100.4 or 38 degrees Celsius, without any intracranial infection, metabolic disturbance, or history of afebrile seizures. And the prevalence is between 2 to 5% of all children, and most children are going to have it between the ages of 18 months to 24 months, but we can see it from, by definition, from age 6 months to age 6 years, and it's more prevalent in boys than in girls. As you can see, that the incidence below 6 months is only 4%, while the incidence below 3 years is 94%, and above 3 years is 6%. So if we have a child who has it at the age of 6 months, it's a little bit unusual. Or if we have the first febrile seizure in a child who is older than 3 years, this is again a little bit unusual. In a third of the cases, it will recur. And in 10%, children will have multiple recurrences. Now, the chances for recurrences are higher, up to 50% if the child had his febrile seizures below age of 1 year, and about 20% in children who have it at the typical age, that is around 1 to 3 years of age. And we classify the febrile seizures into actually 3 categories, but 2 main categories, which will help us then to decide what kind of workup and treatment should we do. So the simple febrile seizures are febrile seizures that are generalized, and generalized mean usually either tonic-clonic, which we saw in previous videos where we have a tonic phase and then a clonic phase. Sometimes it might be only clonic, so shaking or jerking of both arms and legs, and sometimes it's more tonic, where you have increased tone in your extremities. It is less likely to be a seizure that is like an absence, where you're just staring. That would be a little bit unusual. It is less likely to be a seizure where you just drop, or an atonic seizure. That would be a little bit unusual. And the duration of the febrile seizure is usually 2 to 3 minutes, sometimes 4. But for simple febrile seizures, up to 15 minutes, we put it in the simple classification. About 30% of the cases will be complex febrile seizure, where there's going to be some kind of a focality. So a focality might be either head and eye deviation to one side, might be just clonic shaking of one side, might be what we think is a complex seizure, complex partial seizure with lip smacking, twitching of one side of the face, or if it's longer than 15 minutes, or if we have more than one febrile seizure within 24-hour period. So let's say we had one and then we have another one in 3 to 4 hours. And about 10% of children, their first febrile seizure is going to be febrile status epilepticus, with the definition that is longer than 30 minutes. So it can be either one seizure longer than 30 minutes, or it can be recurrent febrile seizures where the child does not regain back its baseline mental status. So what is the recurrence risk? So there's multiple studies that were done, and some of them looked at different parameters. But the consensus is that if you have a febrile seizure below age of 1 year, or family history of epilepsy, or family history of febrile seizure, or if you have a complex febrile seizure, or if you had the seizure either immediately as the first sign of your illness, or within an hour of the fever, so it's a short lag from the fever to the seizure. If you have a low degree of fever during the seizure, if you have developmental delay, or if you go to daycare, you have much higher chances to have a recurrence. And if you have no risk factors at all, the recurrence rate is going to be about 15%. But if you have 4 or more, then it goes up to 75%. So what is the workup for first febrile seizure? So first we have to try to identify, is there any infectious source? And especially we are talking about CNS infection, of course. But we know that febrile seizure, actually one of the major etiology that we identify is the human herpes virus 6 or otitis media. So we have to identify the source. And then what do we do with the lumbar puncture? In the past, there were clear indication. I remember that when I was in residency many years ago, any infant below the age of 12 months who came to the emergency room with febrile seizure, it didn't even matter if at that point in the emergency room the kid was smiling and laughing, we had to do a lumbar puncture. So some of the recommendation change nowadays. So of course, on clinical basis, if the child is altered, if the child is not back to baseline, if the child has meningeal signs, we have to worry about CNS infection, we will do a lumbar puncture. In infants less than 12 months, we have to consider it strongly, and especially consider it strongly if they were not immunized or if they're treated with antibiotic, let's say for otitis media that was identified a few days before. Routinely, there is no really need to do any blood studies, and this now depends on the clinical situation. EEG is not necessary in simple febrile seizures, as well as imaging like a brain MRI or a head CT that are not necessary in simple febrile seizures. It becomes a little bit more complicated when we have complex febrile seizures. In many places, if you have a complex febrile seizure, let's say that you had clonic shaking on one side of your extremity, they would recommend then to do an outpatient imaging to rule out any, for instance, structural abnormality. So what is the treatment for febrile seizure? So the acute treatment is to treat it as any other seizure. First aid for seizures, where you make sure that the child is safe, you lay him on the side, head a little bit turned down to make sure that they don't aspirate on secretion, and you time. You look at your clock and you start timing. And if the seizure is longer than, we in BMC use 3 minutes, in the literature they say 5 minutes, then you would like to try and abort the seizure, either with rectal diazepam, or if EMS are around, they can give intranasal midazolam. And why did it change? In the past, we actually didn't treat it as fast. But it is very clear nowadays that if the seizure goes beyond 5 minutes, there is very low chances that the seizure will abort and resolve by itself. And we know that when the seizures are more prolonged, it's much harder to stop them, even with treatment like the rectal diazepam. So it is kind of interesting. We know that all the benzodiazepam actually work on the GABA receptors, which we have on the surface of the neurons. And after a few minutes, there's an internalization where the GABA receptors internalize, and now they're not anymore on the surface, so it's much harder for the medication to work and help to stop the seizures. What do we do for a prophylaxis? So a child came to us, had 1 febrile seizure. So the most important thing is parents' reassurance and education, because it is very frightening to see your child with a generalized tonic-clonic seizure, even if it's relatively short. So most febrile seizures are relatively benign, and the children outgrow them and do very, very well. So we educate the parents about the natural history of febrile seizures and what to do for first aid. What about fever reduction? So we usually recommend that if a child has fever, we should and has a history of febrile seizures, we should treat for the first 24 hours with over-the-counter medication like Tylenol or ibuprofen. But there's actually no studies that show that there's no difference at all in prevention of further febrile seizures with fever reduction. So we can recommend it mostly if the child doesn't feel comfortable, if the child has high fever and is irritable, but it is not really going to help with the reduction of the recurrence of febrile seizures, especially in the cases that many of these febrile seizures are actually the first sign and the parents even didn't know that the child had a febrile seizure. Another approach that we may use is intermittent benzodiazepine, and there was actually a large study done by one of our faculty in Boston Medical Center, Dr. Rossman, who looked into giving diazepam, PO, every 8 hours when a child develops a febrile illness to try and prevent further febrile seizures. So what it showed that actually this intermittent benzodiazepam might be helpful in reducing some recurrence of this febrile seizure, but the critic was that to get this result in one child, you actually treat 14 children unnecessarily. So most of the time nowadays, we do not recommend this intermittent benzodiazepam in children who have either just simple febrile seizure or have even complex febrile seizure. We do sometimes recommend it in children that we know that have multiple seizures in one illness. And seizures tend to repeat themselves in some way. So if a child always have a cluster of febrile seizures during one febrile illness, I sometimes do recommend, and the parents usually would give it after the first seizure. And many of them would not start it just at the febrile illness, because not every time that you're actually febrile, you may have a seizure. And then what about daily anti-epileptic drugs? So in the past, and I'm saying in the past, it's in the United States in the past, but we have a lot of immigrants that come from different countries, and I still see children who have febrile seizures and are treated with phenobarbital or valproic acid Depakote as a daily anti-epileptic drugs. So this is a no-no. We know that the risk of this medication is much higher than the benefit. What is the prognosis of febrile seizures? And when we talk about prognosis, we mostly talk about epilepsy risk, because the likelihood of mortality is very, very low. So if you have a simple febrile seizure, one simple febrile seizure, your chances to develop epilepsy is the same like the general population, is about 1%. The major risk factor is if you have febrile seizures and some developmental delays, or if you have focal complex febrile seizures. So you had febrile seizures that are not two in febrile illness, but if it's complex due to focality, or if you have epilepsy in a first degree relative. This is kind of the three major ones. And then there's also risk if the seizure started with a short leg or fever, or complex febrile seizure at any type is about 6%. And if a patient has recurrent febrile seizures, it's actually 4%, which is 4 times more than the recurrence risk of epilepsy in the general population. So what are the red flags for us to think about, or for you guys to think about when we see a child with febrile seizures? So we have to reassure parents most febrile seizures are benign. However, they can be first presentation of epilepsy, or they can be an indicator there is some CNS infection going on. So if the child does not return to baseline and they're in the emergency room, we have to think about infection and do an LP. The other thing that we can think about is he actually non-convulsive status epilepticus? And we don't see the movements, but the brain itself is still seizing. And of course, we have to think about possibility of a head trauma. If the febrile seizure is in a child who is younger than 1 year of age, and especially if it is prolonged, it might be first sign of some of the more catastrophic epilepsies. If the focal febrile seizure, if we have a focal febrile seizure, especially if it's clonic movement, either of the arm, leg, or face, if you have febrile status epilepticus, or if you have a seizure with low-grade fever, can be, again, that it's actually a sign that this is evolving epilepsy and not really a true febrile seizure. So I wanted to talk with you just a little bit about the genetic epilepsies that usually start with febrile seizures. And I have to say that lately, with all the new technology and all the genetic testing, we have actually more and more patients where we identify with these disorders. So these are patients who start with febrile seizures usually at around 6 months of age to 1 year of age, but there is something atypical to their febrile seizure. And what would be atypical is that it's usually quite prolonged. They might present with febrile status epilepticus, or they're focal. They start with one side of the body. And then many times after 1 year of age, they start with afebrile seizure and develop multiple seizure types, especially, for instance, atonic seizures, where they kind of just drop 100 times a day, myoclonic seizure, which is this very fast jerkiness, and may develop also other seizure types. And then usually by age 2 to 3 years, we start to see either some plateau or regression in their development, regression in their gait, and so on. And the typical one that we think about is what we call the GEFS plus, or genetic epilepsy with febrile seizure plus. So it's children who many times have a family history of febrile seizures, or have a family history of febrile seizures that then evolve into epilepsy. It's usually autosomal dominant, and many times it might be an epilepsy that does not get to the worst spectrum, which would be Dravet syndrome, but might stay either just in children who have febrile seizures who go beyond the age of 6 years or 7 years. They might have it also later a little bit, or children who develop also other seizure types except for the febrile seizure. Not all of them are catastrophic. Some of them, the children may outgrow it, and I have few probands where grandfather had febrile seizure, father has febrile seizures, and then epilepsy that he outgrew at age 18 months, and now daughter had febrile seizure, multiple atonic seizure, myoclonic seizure, but actually doing quite well developmentally, and all of them have this mutation in the sodium channel, SCN1A, which is kind of the most common one that we now find. It is important to identify, and it's kind of a spectrum, and I'm not going to go into all of them, but it's kind of important to identify, because these children, not only that they have a lot of febrile seizures and then develop epilepsy, if we treat them with different medication, for instance, like trileptal, which is a sodium channel antagonist, we can actually make their seizures much worse. The same with lamotrigine or lamictal. So it's really important to identify this genetic syndrome. The other thing that is very important is they're very sensitive to environmental heat. We have a little boy who is probably in this Dravet syndrome, who presented in the last months twice to the emergency room with a status epilepticus of over an hour when it was 90 degrees outside. So mom takes him outside, it's very hot, and he develops a very prolonged status epilepticus without even having febrile illness. The other thing that is important, these children, for instance, are not allowed to have hot baths. Just having a hot bath may cause a prolonged seizure. The other thing that I wanted you guys to know a little bit about febrile seizures, so the most common adult epilepsy syndrome that is very refractory to medication, and usually they are not controlled and they need to go into surgeries, is what we call mesial temporal sclerosis, where part of the temporal lobe, the hippocampus, looks sclerotic, and the seizures arise from that area. And they have the typical temporal lobe seizures, which are the complex partial seizures, start with gastric uprise, some kind of lip smacking, and they may then generalize. So there was always a question when you ask an adult with mesial temporal sclerosis, quite a few of them have a history of febrile seizures. And the question is, so is the febrile seizures actually the cause of this mesial temporal sclerosis, or is it just incidental? And there was lately a big study done, and it's not BEBSTAT, I have a typo there, it's called FebStat. And they did a prospective study where they take each child in 5 centers who had febrile status epilepticus, so febrile seizure longer than 30 minutes, and they do immediately an MRI at the acute phase, and they follow them each year with a repeat MRI. And what they showed that it was about 22 children out of 220, it was about 12% showed acutely an edema in their hippocampus with T2 hyperintensity. So this is an edema. And over a year, a majority of them evolved into what we call hippocampal sclerosis, where there's actually atrophy of the hippocampus. And a large majority of these children, the study is relatively still going on, but a large majority of these children might in the future develop this mesial temporal sclerosis. So there's clearly some correlation between prolonged febrile seizures, so over 30 minutes. Therefore, we want to attack them and stop them at 5 minutes, and then we don't want to wait too long, because if we wait too long, we might increase then the risk of hippocampal sclerosis and later epilepsy. The other syndrome that I would like to talk with you about it, and then we are going to be done, is febrile infection-related epilepsy syndrome, or FIRES. And I don't know if you guys heard about it, but so it's quite rare, but more and more do we hear about it. So it's children who had some minor febrile illness, usually a week before. Sometimes there's maybe a little bit of temperature still going on. It was really nothing major. The kids were totally fine, and then they have these explosive refractory seizures where they come with multiple, either generalized tonic-clonic or more commonly multifocal seizures, complex partial seizures, hundreds a day. And whatever we do, we can't stop them. It's usually in school-age children between ages of 3 to 15. It's seen more in boys than in girls. Interestingly, the same like febrile seizures that we see more in boys than in girls. And the etiology is unknown. These are the children who get $1 million workup, including, of course, infectious, autoimmune, genetic, and we don't really find a cause for it yet. But the thinking is that it is either immunological or inflammatory factors that play into it.